Hello, I'm Hematologist Oncologist Dr. Tony Talebi. Now we're going to discuss the treatment of non-resectable, non-transplantable liver cancer. The pleasure of being with Dr. Fon, Professor of Medicine at the University of Miami. Thank you for being back.
My pleasure.
Okay, now let's take a situation where a patient has liver cancer, but for sure is not a resectable candidate or a transplant candidate. What happens next for that patient?
We'll evaluate the patient individually and decide what are the best options for them. There are certain patients who tumor can be downstage, where if they're not resectable immediately or not a candidate for liver transplant, sometimes if we get a good response to treatment, it may be through chemoembolization of the liver, maybe ablation therapy, maybe a combination of therapy. But if we can shrink the tumor down enough, some patients may be rendered resectable or candidates for transplant. If they're not a candidate for transplant or resection after those therapies, there may be different therapies that may be palliative, may help to control the liver cancer.
I see. Let's talk about some of these procedures that are so important in your field. What is radiofrequency ablation, RFA?
Radiofrequency ablation is a procedure where needles inserted into the liver. It can be done either through the skin under guidance of ultrasound or a scan. It can also be done through what's called laparoscopic procedure. You can make a small incision in the abdominal wall and looking directly through a laparoscope, one can insert a needle into the liver. One can give either heat therapy called microwave or radiofrequency ablation, or a procedure called nanoknife, which is administering electrical pulses to the tumor to try to kill the tumor cells and shrink them.
And this is an outpatient or an inpatient procedure?
Generally, it may be a short stay in the hospital, maybe overnight procedure, but it's a very short process, can be given over just 1 to 2 days.
Are there any significant risk factors associated with it?
The risks for doing these procedures include risks of bleeding and infection. In some instances where the liver is severely damaged, there's a small risk of liver failure. Those are major risks.
I see. And what would happen if someone went into liver failure?
We would give them the best supportive care. In some cases, if they're a candidate for a transplant, one may consider that.
I see. Now what about a procedure called TACE? What is that?
TACE is a procedure where a catheter inserted into the groin, into the artery, is thread up into the liver, and chemotherapy is infused into the liver, either chemotherapy infusion or sometimes chemotherapy beads, and the circulation to the liver bearing the tumor is blocked off, and then the catheter is removed, and the patient will have scans followed to see if the tumor is shrinking after that procedure.
How long do you wait to get the CAT scan?
We normally do CAT scans about a month or so after the procedure in our institution. Some institutions may wait a little bit longer.
And how many times can you perform the RFA or the TACE on any given patient?
There's no strict hard and fast rule. It depends on liver functions and the patient himself, but you can give multiple treatments. Some patients have received 3 to 6 treatments.
So, and that's done once a month?
It's spaced out generally. It may be 2 or 3 months or longer depending upon the response to therapy.
And you can do either side, either lobe of the liver?
Right. The main thing is we have to make sure that the circulation is adequate to the liver. The liver main blood supply is a portal vein, so the portal vein must be patent or open for the patient to be able to tolerate the embolization.
I see. Now what about stereotactic radiotherapy? When do you utilize it and what is it?
Stereotactic radiosurgery is another way of administering radiation therapy to the liver. It involves concentrating beams of radiation to the liver tumor and trying to spare the normal liver.
What about Citrix microspheres?
There are various ways of administering chemotherapy and blocking off the artery embolization. One is infusing beads containing chemotherapy drugs, which can release the drug, as also block off the microcirculation to the tumor.
It sounds like there's so many options at your disposal. How do you, in your mind, decide which one to utilize?
It depends upon the individual patient and a functional liver. In patients where the liver function is not great and cannot tolerate the embolization, we may consider ablation. If tumors that are small enough for ablation, they have to be less than 5 centimeters and preferably smaller than that to have the best effect. So it depends upon the function of the liver, depends upon how many tumors are present. It depends on whether there's portal vein involvement. There are multiple reasons, factors involved in deciding which is the best treatment for the patient.
That sounds very complex and very interesting.
We have a tumor board here in Miami where we meet together with the liver surgeons, the pathologists, the radiologists, and the other doctors involved, and medical oncologists decide the best treatment for the patient. Because some of these patients are complex and require a gathering of minds to discuss the best treatment for the patient.
I agree. How do you address pain in your patients with liver cancer, since the liver is the main organ that breaks down the metabolites of so many of the pain medicines?
Well, sometimes patients will have abdominal pain from the liver cancer, and we give various pain medications to try to control their pain. Maybe different narcotic drugs. We try to tailor it to each patient.
Do they have to take a lower dose than other patients because the liver is damaged?
Some patients are more sensitive, so we have to be careful, particularly long-acting narcotics, that to be able to tolerate the narcotics and avoid the side effects.
I see. So the fentanyl patches and the long-acting morphine should be used with caution?
Yes, and the doctor may have to individualize that and start off the lowest dose possible so he can get the best comfort for the patient, yet not risk overdosing the patient.
I see. But what are your thoughts about the use of alternative herbal medicines that so many patients take with stage 4 cancer?
Those must be taken with a grain of salt because many times we don't know what the side effects of alternative drugs are. For example, sometimes high-dose vitamins can cause liver damage. So, and also certain herbs may have effects that we're not aware of. So generally I advise the patient to discuss it with the doctor because many times these drugs may be tolerated in a healthy individual, but a patient with a damaged liver, they have much more side effects and much more risk. So I need to discuss with the doctor the potential risks and benefits of these alternative treatments.
How do you address the nausea and vomiting that can be associated with any of the procedures that you utilize?
There are various drugs we use that are available to treat nausea and vomiting for these patients, whether they get chemotherapy or just have the nausea from the disease itself. And these are available to the patients and can be prescribed by a doctor.
I see. What about exercising? Do you recommend that for your patients with liver cancer?
Generally, I recommend the patient can do exercise at their own rate, their own tolerance. Each person is different. If the patient is feeling well enough to exercise, I think that's important. It helps improve circulation, prevent bad sores. At the same time, we don't overstress the patient if they get too fatigued. So I think this needs to be discussed with the doctor and a program plan for the individual patient. We want him up and about and getting some activity. At the same time, we don't make him too exhausted. So we need to go at the patient's own pace and work out a plan for the patient.
What about the situation where the patient has no appetite? How do you address that difficult scenario?
Well, we consider if we can change the diet. There may be certain foods can tolerate. Maybe various food supplements might be way to maintain nutrition. There's also various appetite stimulants that can be used if necessary.
Now, there's a very important medicine that recently has been approved for liver cancer called sorafenib. Would you please explain what is it and when do you utilize it?
Sorafenib is an approved drug for liver cancer. It's a targeted drug that involves inhibiting certain metabolic pathways which cancer cells undergo. And this drug is approved for liver cancer. It's taken by mouth. It has been shown that this sorafenib can, in many instances, control the liver tumor, prevent it from growing, and occasionally will shrink the liver tumor.
What are the side effects associated with it?
The most common side effects of sorafenib are 3. It can cause fatigue, can cause diarrhea, can cause skin rash, or hand-foot syndrome, where they get dermatitis.
What about the blood pressure issue? Have you had any problems with that? Patient's blood pressure is going up?
It's not common, but it can occur, and they need to be monitored by their physician.
What about thyroid issues? Have you ever had any problems with thyroid problems?
It's important that when patients are taking medication, to have their thyroid function checked. The fatigue patients suffer during illness sometimes can be due to low thyroid, hypothyroidism, and sometimes drug can also affect the thyroid. So it's important a patient having fatigue, perhaps to have a screening test. We order a TSH blood test, and it may be important to find out the causes of fatigue in addition to liver.
I see. What about Doxil? Do you ever utilize that in your patients?
Doxil is one of the chemotherapy drugs that's available to treat liver cancer. There are other drugs that have shown some activity in liver cancer and may be good for palliation of the cancer.
How do you know if the treatment you're rendering is working? What do you do?
While we follow the patient closely, we may get serial alpha-fetoprotein blood tests. We'll follow the scans, either a CAT scan or MRI scan, to see if the patient responding. We generally give the patient a couple months on therapy to give it time to work. We get a follow-up scan and blood test to see if there's improvement.
Have you ever been in a situation where the cancer is not curable, but the family does not wish for you to discuss this with the patient? How do you handle that situation?
That's always a difficult situation. I think that each patient is different. I think the doctor needs to be honest with the patient and not mislead the patient. At the same time, many patients come for hope because they want some therapy. And I think that it's important for the doctor to be considerate in the talking with the patient, if the patient wants to know statistics, to be honest with the patient, because many times the patient will do better than statistics will show. I think it's important for the doctor to be very supportive and understand the patient's feelings. We don't want to raise false hopes. At the same time, I think we try to be as supportive as possible, and there are sometimes patients who will do much better than we anticipate. So that may be important to emphasize to the family as well.
I see. How do you deal with depression in patients with advanced liver cancer?
Depression is always an issue. One has to look at the cause of depression. Depression can be also a symptom of fatigue when not eating well. So it's important to determine what is the cause of depression. If it's due to their psychological from facing a cancer, we need to be very supportive. Sometimes we have support staff at Cortellis Center, for example, which may provide psychological and emotional support, and there are support groups as well.
I see. What about clinical trials? Would you please explain what they are, and do you recommend those for patients with liver cancer?
Clinical trials are studies in which we evaluate new drugs and see what the potential benefits are in liver cancer and other cancers. And there are always newer drugs and newer technologies and programs available for patients with cancer. And some of these drugs are promising. And I think if a patient is a candidate for a clinical trial, they should discuss that with the doctor. They're going to be evaluated for that because there are new treatments that may potentially help to them.
I think some people have the misperception that palliative care and hospice are the same thing. Please explain how the two can be potentially different, and when do you refer patients for each?
Well, palliative care is where we try to support the patient, but we realize that we're not curing the patient, but hopefully we can provide support for the patient. In some cases, therapy itself can be palliative. If they're having pain, sometimes the embolization or ablation can help reduce the pain by shrinking the tumor down. Hospice is useful for patients who are at the end stage, who particularly don't want any therapy. We're providing supportive care, terminal care, as best we can.
I think you mentioned this before, but for us, patients want hope from us more than anything else. How do you give your patients hope with very advanced liver cancer?
That's something we have to discuss with the patient. I think we need to understand that in many instances, we're not God, we can't predict how long a patient will live. There are sometimes miracles can occur sometimes as well. I think we need to be supportive in the patient. We try to be positive as much as we can, but we try not to be overly optimistic. We don't want to mislead the patient. But at the same time, sometimes these treatments can be beneficial and may extend their life more than statistics will show. So I think we need to keep that in mind.
Thank you so much.
My pleasure.
Thank you for watching. We hope this has been educational for you as well.